For this, I would like to invite Dr. Devesh Kumawat, an assistant professor at RP Center AIMS, a young and dynamic surgeon, a avid researcher, and a very kind person. Dr. Devesh.
Thank you, Dr. Ankur, for the kind introduction. Good morning to all. So I'll be taking you forward with the basics of OCT angiography. So OCT angiography is a dialysis angiography that we all know, and it constitutes of en-face imaging at different levels in the retina choroid, can be even the optic nerve head. And since there is segmentation of individual layer which is possible, there is no overlap of the vascular structures, and we can visualize the vascular structures in individual slab. Now, since no dye is used here, there are no dye related side effects, as well as there is no leakage, no pooling, so there is no obscuration of the vascular architecture that happens with leakage and pooling, and so we can clearly visualize the vascular architecture in OCT angiography. Now, what is the principle of OCT angiography? Basically, it relies on the decorrelation signals. Now, what are decorrelation signals is that there is a difference in the reflected light from any interface when successive images are taken at a very brief interscan period. So repeatedly you are having multiple scans taken at the same place, and any difference in the signal which is there between the two images, now it is taken that that would be because of the motion. Now since retina is an immobile structure, we presume that that motion happens because of the blood flow. So OCT angiography, it detects the blood flow, it does not detect the the vasculature. So basically it detects the blood flow in the vasculature and not the vasculature itself. Now there are different methods that are used to detect this motion contrast. One principle is the amplitude decorrelation. Amplitude decorrelation means that you're detecting the difference in the amplitude of the reflected light between the successive scans. And the second principle is the phase variance, in which other than the amplitude you detect the difference in the emitted light wave properties rather than the amplitude. You are focusing on the phase of the light which is reflected back. Now there are other methods to improve the signal quality in OCT angiography, and accordingly you name the algorithms according to that, such as split spectrum OCT angiography, that is the amplitude decorrelation angiography. Then you have the speckle variance and volume averaging. Now, I have no financial interest, but there are multiple platforms that are available commercially, and they have their own trade-offs. Now, the important thing to remember here is that these platforms will segment differently. So, majority of them will segment the VR interface anywhere from the ILM to 200 to 300 microns. Then you have the superficial slab, which is between the ILM and the inner plexiform layer. Then you have the deeper layer, deeper vascular plexus, that is layer which is in between the IPL and the outer plexiform layer. Then you have the outer avascular zone, which is basically from the OPL to the retinal pigment epithelium. Then you have the sub-RP and the choriocapillaries and choroid. So there is some difference between the individual platforms. Each one have their own advantages and disadvantages. So some of them are spectral domain OCT based, whereas others are swept source. So on the left side, you can see it's the Spectralis by Heidelberg. Again, no financial interests. And on the right side, you can see it's a Angioplex OCT angiography by Cirrus, Carl Zeiss. And this one is the swept source OCT angiography, that is the DRI OCT by Triton. And the important difference between the swept source and spectral domain here is again the penetration, better penetration that we achieve with swept source OCT angiography, and otherwise the principle remains the same in both of these. Now, it is important what scan size we should choose while we are going ahead with the OCT angiography of the tissues. Now you can have different scan size available in different machines. Traditionally we have 3 into 3 mm or 4.5 or 6. Now longer or larger scan size are also available in the few of the machines, such as long as 12, and now we have the ultra wide field also coming up, which can provide even view till the mid periphery. Now important here to differentiate between the scans is that the resolution will depend on the scan size. So even though we can achieve a larger scan that will provide us a better, larger area to evaluate, but on the left side you see it's a 3 mm scan, and on the right side it's a 6 mm scan. In the left side, we can see the microorganisms, but in the right side, we cannot see the microorganisms that clearly. So the resolution does decrease in a larger scan, and also there is a problem of artifacts coming in because you are detecting a motion, and bulk motions because of the eye movements can occur if the scan acquisition time is prolonged. Now coming to the interpretation, whenever you are interpreting an OCT angiography image, you have to do a concurrent assessment of multiple things that you have to take care of. First, you have to make sure that the area of interest is captured and the scan is properly centered. Then you come to the en-face OCT images in different slabs. Before jumping to any conclusion on these images, you need to check the corresponding B scans, whether the proper segmentation is done or not, whether if you're looking at the superficial plexus, whether it is segmented from the ILM to the IPL or not in the OCT B scan. And then you also check the flow overlay, because sometimes the abnormality may be very minute, the membrane, an abnormal membrane may be there which may be very small, but you may still be able to pick any flow on the OCT overlay, and that will be depicted by the hot color red. Then at last, you also have to look at the structural en-face OCT image, intensity image, because your signal may be impeded because of any media opacity which is there. Maybe it is the hemorrhage, maybe it is drusen's. So the signal intensity may be reduced, and you may misinterpret it as a flow void or a flow deficit, and otherwise it would be just a decrease in the signal intensity, which is because of impeded transmission. Now different artifacts can occur in OCT angiography because it's a very sensitive tool. It will be affected easily by any movement of the eye, or there are other side effects, other artifacts as well. So coming to the motion artifact, it occurs because there is some movement which is there. Although there is eye tracker present in all majority of the machines, the threshold may be outside the threshold of the machine, and small movements may still not be compensated. So these motion artifacts will appear as white streaks across the image, and to how the machine takes care of it is that it may rescan the affected area if that option is there, or you can have softwares which correct this motion artifact using horizontal and vertical raster scans. So using the horizontal and vertical raster scans, you can know what is the displacement of the image, and then you can align the image using the software and get a motion artifact free image. Now next is the projection artifact, which is basically an erroneous appearance of the superficial vascular network onto the deeper networks, onto the deeper levels. So in this image, you can see the superficial plexus, which is visualized here, the large vessels which are visualized. But when you see the angiography slab at the level of choriocapillaries, still you are able to see these large vessels which are erroneously appearing in the deeper slab. Now why does it happen is because at any deeper level, whatever light intensity is coming, already it has been affected by the flow which is above it. So if you are looking at the choriocapillaries level, already the light which is coming to the level of the choriocapillaries, it has been affected by the flow which is there in the superficial plexus, and therefore these projection artifacts commonly occur. Now there are different ways these projection artifacts could be removed. Initially we had the slab subtraction, in which we used to subtract the superficial slabs from the deeper slabs, but that leads to loss of the signal intensity, and therefore the machines now they are coming up with newer proprietary softwares aiming at projection artifact removal. So if we see here, this is the spectralis by Heidelberg, and there is the superficial plexus which is visible here. On seeing the deeper plexus also, you can see there is a projection artifact which is there, and in this, if we apply the projection artifact removal option, then the superficial vessels are removed. So in this we can see there is an option to choose the projection artifact removal option, and this can be chosen if you want to remove this, and as a default it is always chosen. And just to highlight that projection artifacts can occur, I have unselected it and shown you the images here. Now segmentation artifact occur because the machine, it automatically segments based on the predetermined retinal boundaries which we have gathered from the healthy eyes. So any alteration which is there in the retinal anatomy, it will make the machine mislabel the boundaries. So if we see this example here, the yellow arrow can make the area in the which is denoted by the yellow arrow, you can interpret it as a flow void or a deficit of the vasculature here. But if you see the corresponding OCT image, you see that the segmentation lines are above the retina in this area. So there is no vasculature in this area. That's why this absence of vasculature is there, and it's not an actual flow void. And similarly, if you see the blue arrow, some vessel complex is seen in the deeper angiography plexus, but however you know that it's a sub RP membrane which is there, and because the segmentation lines are here passing through the sub RP level also, and rather this should have passed above. So the machine is not able to do that, and that's why these segmentation artifacts occur. But you can manually change the segmentation. You can bring it above this hump in this area, and then have a true picture of the angiography deep plexus in that area. Now last is the shadow artifacts. If you see this image, you can misinterpret it as having flow voids in the center, but when you see the intensity intensity image and the OCT image, you know that there is lot of edema which is happening, and this signal transmission is impeded because of loss of because of lot of edema, and it's not just because of flow deficit. So anything like edema, a gross edema or drusens or blood can have this shadow artifact. In this example, we can see there are a lot of drusens which are there, drusenoid PEDs, and erroneously we can see that the shadow is casted here in the choriocapillary slab, and you may misinterpret it as a loss of choriocapillaries in this patient. Now there are different ways you can, different matrices that are available with us. Since we are very beautifully able to capture the vasculature, we can even quantify it. So the traditionally we have the vascular density and the perfusion density and the phase metrics which are available with us. So on the left side, if you see, it's the vessel density metrics that are shown. Vessel density is basically length of the perfused vasculature. So you consider all the vessels to have a caliber of 1 pixel. You ignore the thickness of the vessels. You consider them as a caliber of 1 pixel, and then you check how much is the length of the vasculature in the per unit area given. And on the other hand, if you see the perfusion density is basically the area of the perfused vasculature, that is, the thickness is also included here, and then you calculate the perfusion density. The phase, you can have an automated phase metric such as the phase area, the circularity index, and the perimeter or the circumference, and you can manually also calculate it. If the machine is not able to do it, you can trace the phase and calculate these manually. Manual or semi-automatic threshold segmentation can be used, also be done using ImageJ softwares, and there are different thresholding algorithms which binarize the images into perfused and non-perfused, and according to the pixels, white pixels and the total pixels, you can calculate the perfusion density. Now important here is that you should use the same algorithms which are used if you want to compare the data on follow-up, and you should not compare in between the different platforms which are available, because always different thresholding algorithms will give different results. Now other factors, other matrices that are available are the fractal dimension, vessel diameter index, lacunarity index, and the flow void densities. These are being looked up into in the upcoming research studies, and there are other image processing systems also available other than ImageJ that can be used, such as Fizzy, AngioTool, Octave. Coming to the limitation, that is my last slide. So you have certain limitations of OCT angiography, that is the field of view may be limited, although we are coming up with wider ultra wide field scans also, but they are affected by motion artifacts and other artifacts. You have the segmentation and the projection artifacts that may impede the quality of your scans. Then the vascular structures with low flow, such as microneedles and polyps, may not be imaged well, and they may be missed, and you may not be able to differentiate between leaky as well as non-leaky abnormal vessels, and cannot comment on the transit time in OCT angiography. Thank you.
Thank you, Dr. Devesh. So I would like to thank you that you have summarized the all basic of OCT angiography in very crisply. Just one question that I think I wanted to ask you. You have been, being in RP center, you have availability of swept source OCT angio as well as, other OCT angio spectral domain. So for a beginner retina specialist, what do you think should be the ideal way? Should he invest more to buy a swept source OCT angio, or is it good to start with just the spectral domain OCT angio?
So I have shown you the images, even the Cirrus, that is the Angioplex by Carl Zeiss, it also provides beautiful images. I have used it at AIMS Rishikesh and LHMC also, and I was able to use it in my clinical day-to-day decision making. So that is also good enough. And the Spectralis by Heidelberg, sometimes I feel that provides a better slab information rather than the swapped source imaging.
Thank you. So,
Can I?
yeah.
So, just for the benefit of everyone, so you beautifully highlighted how OCTA is done, what are the side effects, you can say artifacts, and then what are the limitations. What are the clinical cases where you feel now you don't need to do FFA at all, but you do only OCTA and it's done?
So where you don't have a clinical first is when you want to confirm, when you want to intervene and you want to confirm, you need not go for an FFA, just document it using an
In,
OCT
in, in,
angiography.
in which
And
variety of cases? I mean, diabetic retinopathy, which
so
disease?
CNVM, if they are clinically, you can visualize the CNVM. You need not go ahead with an fluorescein angiography. Just document it with OCT angiography. And sometimes when you have small membranes which are there, they may be picked up on the OCT angiography, and you need not do a fluorescein angiography in those patients. And also on follow-up, when you want to see the change in the network which is there.
So one category of cases you want to say is when you have macular neovascularization or
And
neovascularization due to any
second
cause.
would be the CNP areas. We can pick up the macular ischemia also on OCT angiography. Need not go with fluorescein angiography in maybe old BRVOs when we have suspicion of BRVO, that it could be an old BRVO. Vision is unexplained, so we can go ahead with OCT angiography and look for macular ischemia on that.